Welcome to the Clinical Supervision webinar series from the Department of Medical Education. My name is Dr. Charlotte Denniston. I work as part of the Excite program in the DME, and in partnership with Goulburn Valley Regional Training Hub, we are putting together these webinars for you. Our session today is titled Creating Learning Opportunities with Limited Time. Before I get going, I want to acknowledge the traditional owners on the land on which I am at the moment, the Wurundjeri people. And acknowledge also the traditional owners on the lands that you are on as you're listening to this webinar, and pay respects to elders past, present and future. So the learning outcomes for this session are to discuss the clinical environment as a teaching and learning environment, and to reflect on the learning affordances that already exist within those clinical learning environments, and identify some time-efficient strategies in order to maximise learning opportunities in the clinical learning environment. I'm not going to tell you how to make more time, but I think part of today's session will be hopefully encouraging you to think about how you can maximise the time you already have and think differently about the activities that you do within that time. So first up, we'll talk about the clinical environment as a teaching and learning environment. We know that there's many challenges to clinical teaching. There's time pressures, competing demands, the fact that clinical teaching occurs in a place where the primary role is patient care or client care. Often clinical teaching is unplanned and opportunistic. It's often under-resourced and under-rewarded. At times, the patient mix can be variable, which makes planning and designing teaching activities difficult. And often there's a mix of learners and a mix of levels, which makes the pitch of the teaching quite difficult also. But I think it's important for us to not forget the strengths of the clinical teaching environment as well. As Spencer has put here, you know, it's the only setting in which the skills of history taking, physical exam, clinical reasoning, decision making, empathy and professionalism can truly be taught and learnt together as an integrated whole. It is the authenticity of the clinical practice setting that is so rich for learning and teaching. Some common problems with clinical teaching though, and this is based on the literature and I'm sure it relates to some experiences that you've had, are that often there's a lack of clear objectives and expectations, both from the student's perspective and also from the teacher or the educator's perspective. Often clinical teaching focuses more on factual recall rather than the development of problem-solving skills or attitudes. Teaching can often be pitched at the wrong level. The literature says that usually too high, teaching is pitched too high, but perhaps it could also be pitched too low, and some of this does relate to the lack of clear objectives and expectations. Often our learners are positioned as passive observers rather than active participators, and this has been reported as a common problem with clinical teaching. There's also in some settings inadequate supervision, inadequate provision of feedback or feedback conversations, often little opportunity for reflection and discussion from the student's perspective, but also from the educator's perspective. And at times there can be a lack of congruence or continuity with the rest of the curriculum. So the idea that what is taught at university is not necessarily reinforced at clinical placements, and vice versa, that perhaps what's happening in the real world is not what's happening at the university. So there can be a mismatch there. When we think about teaching in general, and for this, the purpose of the session today, I wanted to bring it to the clinical environment. I think it's important to clarify the different types of curricula or different types of teaching and learning that can occur. So Hafferty talks about the formal curriculum, and this is the explicitly stated, intended or planned teaching that occurs, and this does occur in the clinical environment. These are things like tutorials, lectures, workshops, so planned sessions that have a clear objective and we can control them to a certain extent. Then there's also the informal curriculum. Often this is unscripted, without formal planning, those ad hoc on the fly opportunities for teaching and learning. This can be things like observation or role modelling or suggested readings. And then finally, there's the hidden curriculum, which is the least controllable aspect of them all, which is the impact of structural, systemic, cultural factors on the teaching and learning. And often these are things, as the name suggests, that we can't necessarily see, but influence learning outcomes significantly in the clinical environment and also in the academic environment. A lot of what happens in the workplace, so the clinical setting, is more around the informal or the hidden curriculum. A lot of aspects of professional practice are learned this way, and therefore a lot of this kind of curriculum is highly influenced by context. So depending on where you are, that will influence what kind of things you will learn from the informal or the hidden curriculum, because they are not controllable like the formal curriculum we suggested earlier. So with saying that, I think it's important for us to acknowledge the context that we're in, the clinical environment as a context for learning. From an ecological perspective, context is described as a range of different things, and it's quite complex. Context is described as that which surrounds or contains. So in the clinical environment, this could be the physical setting, that which is done or experienced. In the clinical environment, that is really patient care, but learning also occurs. Context is also described as what those involved bring to bear. So it's the stakeholders involved in that learning environment. So patients, learners, healthcare professionals, other staff involved in the care delivery in the clinical context that you're in. And context is also described as culture and its values and practices and rules. And we know, I'm sure you've experienced this with different workplaces, that each workplace has a unique culture. And this can influence learning as well. It's important to remember that some of these aspects of context will be familiar to some people in the environment and unfamiliar to others. And if you think about your workplace, it's familiar to you, but it may be unfamiliar to your learners. Often our learners move from different context to different context throughout their study, and this can have an impact on how they engage with and learn from that context. And we know that different contexts afford different opportunities for learning and teaching. And this is really key, because if we're trying to think about these contexts as a clinical learning environment, we need to see what each context can provide. So for example, we have two settings here. If we think about the affordances or the opportunities for teaching and learning that are offered in these two settings, on the left we have a general practice in regional Victoria, and it's a Shepparton University of Melbourne general practice setting. If we think about those elements of context, this physical setting is quite different to the setting on the right, which is an emergency department with a current patient requiring a whole range of health professionals involved in their care. We can also see that the work to be done is quite different. People are coming to attend appointments at this general practice clinic. It doesn't seem that there is a lot of urgency in the way that they're attending compared to the activity or the work to be done in the emergency setting. Likewise, the people involved are quite different. In the general practice setting, perhaps there's administrative staff, the GP, the practice nurse. But here in ED, there would be a range of doctors, emergency physicians, nurses, other allied health involved, and the patient and potentially their family as well would all influence this context, and then therefore the opportunities for teaching and learning. And we know that the GP clinic versus an ED will have different unique workplace cultures as well. So if we think about our learners, they will have very different ways in which they engage with the learning opportunities in these different settings. For example, a first-year physiotherapy student may be engaging with the general practice setting in an observation way, and they may pay attention to this lady on the crutches and connect with what their learning goals are. But likewise, a first-year physiotherapy student in the emergency department might be completely overwhelmed. But if we swap that learner for a final year emergency training registrar, you can see that the affordances or the opportunities for learning are going to be very different for them in these two different contexts. So it's hard for us to sort of think of one size fits all, but our roles as educators is to maximise the learning in our contexts according to the environment and according to the learners that we have with us. So as regular members of your community or of your workplace, you as an educator, you can readily identify the opportunities and the affordances for learning in your setting. And it's proposed that educators can use this knowledge to develop a contextual curriculum. So teaching and learning activities that are fit for your context. In order to do this, Bates, LOA and Watling encourage educators to think about their affordances. So what opportunities exist in your context? How are these adjusted based on your clinical setting? And then how are these adjusted based on your clinical learners? I'll just give you a moment now to think what affordances for learning exist in your clinical context. What might your contextual curriculum look like? A program of teaching and learning that's unique and relevant to your context. Perhaps you could pause the webinar and think about some aspects of your work context that would apply to this. This next slide might help you to unpack context a little further, and I encourage you to follow up the reference listed at the bottom of this slide, which has some more prompts for you to understand your context. So one question you may ask is, well, what is your practice setting? An example might be you're in an emergency department in a relatively young community. There's lots of young families with lots of transient work. So the learning affordances or the opportunities that might exist in your context, but not others, is that learners have the opportunity to engage with a range of different socioeconomic patient demographics, as well as perhaps specific clinical presentations. So many young families, there may be more obstetric patients or paediatric patients even, and there may be more workplace injury issues with these transient workers coming through from the mines. Another question you might ask is, what other professions do you work with? So in emergency, an ED physician would work very closely with the nursing staff. So what are the learning affordances or opportunities that exist? Well, learners who come and work in your context may have the opportunity for greater interprofessional learning and learning the value of teamwork with medical and nursing staff in the emergency department. The other thing to think about in your context is the number of learners. So are there other clinical learners around? In this example, perhaps no, there's just one learner. So the opportunity that learner then has is to be able to be supported independently in their practice, as opposed to if there were 5 learners who are currently in that learning context. Some other questions to consider for you to unpack and think about your clinical learning environment and the opportunities that already exist include things like, what is your scope of your practice? How can you highlight the differences and similarities of someone in the same profession, but in a different context? Does your scope of practice change being in a rural setting compared to a metropolitan setting? What is possible and not possible because of your location? Have you had to be creative because you have less access to resources? So what opportunities do learners have to identify different ways of practice because you don't have the funding that other contexts may have? Likewise, what are the local values and beliefs of your community, and how do they shape the ways in which patients might present for care? And how does that impact on learning, and how might that be considered by your student for learning? It's important to recognise that these things change, they're not static, but taking the time to consider the true aspects of your clinical context can be helpful to develop your contextual curriculum. The important thing, though, is to think about how this relates to your learners' goals. Remember the example of the first year physiotherapy student and the final year emergency registrar? They're going to have very different goals. So how are they met by the contextual curriculum of your workplace setting? Now we're going to move on to think about how we can be more efficient with our strategies for teaching and learning based on that clinical context idea. In order to maximise learning in a clinical setting, many authors propose that we need to not underestimate preparation. It seems counterintuitive. However, it's proposed that we need to spend some time in order to save some time. Part of this might be putting in some time prior to students arriving to contextualise your curriculum, to be responsive to the affordances and the opportunities of your context. And the next part of that would be to plan your teaching. And now, I'm not suggesting that it needs to be as explicitly planned as, say, a formal curriculum or a tutorial curriculum. However, the principles of a lesson plan are important for us to know whether or not our teaching is being effective, not just quick and efficient, but whether it's being effective. A lot of inefficient or poor teaching in clinical sites happens because there is a lack of clarity about goals and expectations. We learnt that earlier in this webinar. So if we can be clear about what our goals are, what kind of teaching and learning activities are available in our context, and then assess whether or not these goals have been met, we can hopefully ensure that our teaching is not only maximising the opportunities, but also effective in what it's setting out to achieve. So 3 kind of steps for effective and time-efficient clinical teaching is based on some work by Irby and Bowen. And again, I direct you to the references, which will be at the end of this webinar. So the things that Irby and Bowen suggest that we look at are planning, the teaching itself, and then evaluating and reflecting. So in the planning session, I encourage you to think about, who are you teaching? What are you teaching? And where are you teaching? So think about your learner and their goals. Have a conversation with them to identify their goals. Clarify their expectations, your expectations, and the purpose of teaching. And also consider your context and the affordances that exist. As I suggested, perhaps this is something that you've done prior to learners arriving in your site, where you've unpacked, using some of the question prompts we talked about earlier, all the opportunities that exist in your context. The next thing to consider are your teaching activities, or how things will be taught. And so identifying, I guess, those affordances or opportunities that relate directly to your learners' goals, and the appropriate method and strategy for those goals and for that level of learner. What is in your toolkit already? How are you going to know how to teach this particular learner that particular goal? And finally, how are you going to know whether or not they've achieved this? This is not just about assessment or workplace-based assessment for the university purposes, but this is about assessing whether or not goals have been achieved. And that will differ depending on what the goal is. This might be an observation of student practice, it could be assessment of learning, or also provision of feedback. The other thing that's important here is to think, how are you going to know as an educator if it's been effective? It's all well and good to be more efficient and to have greater time strategies for being time poor, but how are you going to know whether your teaching was effective? And part of that is about reflecting on your own teaching, but also getting feedback from students, from peers, or even from patients to evaluate your teaching practices. This can occur on the fly just as much as it can occur before your student arrives, but thinking about a bit of structure can help you be more time efficient in the clinical teaching environment when we know that there is not a lot of time to spare. Now we're going to move on to some teaching ideas and strategies that take on some of these ideas about maximising learning opportunities in the clinical environment. I hope these will be useful for you, and there's many more. I've drawn these from the literature and also from practice. There's some ways to think about the clinical context and how we can maximise what we're already doing, the things that already exist in our contexts, for teaching and learning purposes. Firstly, I wanted to talk about Billett's pedagogically rich activities. So for this particular example, Billett proposes that we take what is happening in practice and optimise it for learning. So he proposes that we consider the pedagogical richness of everyday healthcare activities, or another way of saying this is the educational worth. So what are some things that happen in your context every day? Healthcare activities that are part of your practice, for example, like handover or ward rounds or multidisciplinary team meetings. And if you look at it through the lens of identifying its educational worth, a lot of these activities are very rich and are primed for teaching and learning opportunities. We just need to think about them in a different way. So for example, perhaps you have a learner whose goal is to identify the roles of a multidisciplinary team in the rehab ward. Now, one teaching and learning activity would be for you to spend time preparing a lecture or a tutorial about this. That's not very time efficient. Perhaps another strategy could be for you to prime the learner before a multidisciplinary team meeting. Ask them to observe the ways in which different members of the team are spoken to or spoken about in regards to patient care, and what different aspects that they contribute to patient discharge planning or patient care whilst they're in hospital. Then afterwards, you could debrief with the student to unpack what they learnt about the doctor, the nurse, the physiotherapist, the speech pathologist, and see if you've met that goal of identifying the roles of the multidisciplinary team in a rehab ward. In order to know whether you've done that, you'd need to ask the students, evaluate whether or not this had happened, and you might follow up with questions about other patients in the MDT over time. But this is one way of taking what's happening already in your practice and maximising it or optimising it for learning. The next example is an example from practice at the Royal Children's Hospital here in Melbourne, where they've taken everyday practice such as ward rounds and they've changed it to optimise learning. So they've done a little bit differently to what Billet proposes, in that they've shifted their practice just a touch in order to maximise the learning opportunities for their students and trainees on the wards. So instead of the standard way of delivering teaching on a ward round, which often would end with lectures from senior medical staff on topics that perhaps weren't directly related to the trainees' goals, this team have shifted the way in which they begin the ward round by setting an agenda, clarifying expectations, goals and roles within that ward round so that everyone's on the same page. They then target their teaching. So based on the learner's needs and the learner's goals, and obviously based on what they're engaging with along the ward round, but they target their teaching. So instead of particularly stating a lecture on respiratory illness more generally, if the goal of one of the learners is to identify specific drugs that are relevant to a specific condition, then that respiratory physician will know, well, I need to target my teaching or the patient assessment based around these drugs so that I can reach the goals of this learner. I encourage you to have a look on the website, which is based on the bottom of this page. It really will unpack this model for you and with some videos as well. The next step in this model is the I, which is to inspect and reflect. And this is about not only reflecting on the session itself, but whether the learning goals were achieved. And it's important, finally, to close the clinical and close the learning in this model, where everything is tied together and new learning goals are set, but also priorities for patient care are not left behind. Because again, this is everyday practice. It is a ward round. It's not a lecture, but it's just been maximised to achieve learning goals. Finally, deliberative teaching tools are another way in which we can maximise what's happening in the clinical context. So these particular tools take what already happens, but provide some structure. So these frameworks enable clinicians to have a purposeful and considered approach to teaching encounters by incorporating elements that have been identified in good teaching practice. So for example, there's the SNAPS tool, which is a student-led tool to discuss clinical reasoning and decision-making around patient care. And then also the 1-minute preceptor, which might be more familiar to you, which is educator-led, which again prompts for decision-making and reasoning in the learner. These kind of models are for post-patient encounters, but it provides some structure that achieves objectives instead of a general discussion about what the student has identified. So these deliberative teaching tools have been proposed to reduce the time spent in these discussions by providing some structure and framework. So in summary, we have discussed the clinical environment as a teaching and learning environment. We've also reflected on the learning affordances or opportunities that already exist within your clinical learning environment, so what already happens in everyday practice that can be maximised for teaching and learning. And we've also looked at time-efficient strategies that are currently in practice that are designed to maximise these learning opportunities. I guess my take-home messages really for you are to think about your contextual curriculum, think about your clinical environment as a teaching and learning environment, and what are the unique teaching and learning opportunities that exist. How do these then relate to your learners' goals? Identifying learners' goals should be part of our practice as clinical teachers and clinical educators. So how can you achieve these goals based on what happens in your clinical practice? And finally, to plan your teaching, although it sounds counterintuitive, to think about what are the goals, what are the activities that exist that can help to achieve these goals, and how will we know whether or not they've been met. I encourage you to commit a clinical supervision development goal to a peer or even to yourself. It might be that you will identify 3 activities in the workplace that you can modify to maximise learning. And perhaps one way for you to think about identifying these activities is to do a little bit more reading on this topic and perhaps answer some of the further questions that we talked about earlier. In that case, I encourage you to follow up the Bates, Ellaway and Watling paper that's in bold here that will help to think about the influence of workplace context on learning and teaching and some of the questions that we discussed. However, all the references here are about teaching in the clinical environment and hopefully will be helpful for you in your future reading. Thank you for your attention. I hope you enjoy some of the other webinars that are available on the Department of Medical Education website, and please be in touch if you wish to discuss more teaching and learning activities. Thanks.